This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2014, all rights reserved. My name is Shauna Strickland. I am a respiratory therapist, asthma educator, and Associate Executive Director of Education at the AARC. I welcome you to today's presentation, Ebola virus disease and implications for respiratory care. Upon completion of this AARC webcast, participants will be able to briefly summarize the history of Ebola outbreaks and highlight why persons with Ebola virus disease may sporadically end up in modern healthcare facilities. To describe the expanding Ebola virus disease clinical knowledge base. To describe Ebola virus disease clinical course with specific attention to respiratory dysfunction and failure. To summarize the current understanding of how Ebola is transmitted, and to discuss uncertainties with respiratory care interventions and disease transmission. And to recommend an interim approach to respiratory support which balances patient outcomes and staff safety. I am pleased to welcome Dr. Louis Rubinson, who is Director of the Critical Care Resuscitation Unit at the R. Adams Cowley Shock Trauma Center in Baltimore. He is an Associate Professor of Medicine at the University of Maryland School of Medicine. Dr. Rubinson is a pulmonary and critical care physician and is very familiar with issues relevant to respiratory care professionals. In the past, he was the Associate Medical Director for Respiratory Care at Harborview Medical Center in Seattle. He also has worked closely with the AARC on several important healthcare preparedness initiatives in his previous role with the United States government. In September of 2014, Dr. Rubinson was a World Health Organization consultant clinician at Kenema Government Hospital in Sierra Leone, where he oversaw the care of several hundred persons with Ebola. I disclose that I am a paid employee of the American Association for Respiratory Care. Dr. Rubinson discloses that he is a subcontractor to ICF International for an Ebola preparedness effort for the United States Department of Health and Human Services, Office of the Assistant Secretary for Preparedness and Response. He is the site PI for a United States Department of Health and Human Services, FDA and BARDA contract for the United States Critical Illness and Injury Trials Group program in emergency preparedness. And he was a World Health Organization consultant clinician in Sierra Leone. This talk has not been approved by the WHO and should not be considered to express any official policies or information releases. The details and opinions expressed are only those of Dr. Rubinson. Any uses of images or brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis. Dr. Rubinson, welcome to the program.
Thanks, Shauna, and thank you everyone for coming in the middle of your afternoon. I'm sure all of you are quite busy. For the next hour or so, I'm going to talk about Ebola virus disease, and we're going to take a journey back and forth between West Africa and look at the implications between what's going on in West Africa and its relevance for U.S. healthcare preparedness. Stepping back, even though we've heard a number of officials say that Ebola is new to us, in fact, Ebola has been around for at least 40 years, and there's been 20-odd documented outbreaks, with the first one that really was identified as Ebola in 1976. And in the past, the outbreaks tended to be restricted to rural areas, and in fact, the largest outbreak prior to the current one in 2014 occurred in Gulu, Uganda, in 2000, and at that time there were 425 cases. So you can see we're clearly orders of magnitude different with the current outbreak. In the past, public health and even community-initiated measures were able to successfully control those past outbreaks. You'll hear me talk about the pillars of disease control, but these were successful in the past, the first being early case finding and contact tracing, the second being early isolation of newly found cases, the third being what's considered case management, or what in the West we would consider healthcare, and the last being the proper management of dead bodies. In addition, it's important to note that despite Ebola's rearing its head at different times in history, there continues to be no proven effective vaccine, although there are some exciting candidates that are undergoing early clinical trials right now. And there's also no proven Ebola virus disease-specific treatment. In the past, most of Ebola treatment has occurred in African nations where a lot of the resources that we have in the modern world aren't always available. So many of the details on what care to provide may not necessarily reflect what we can do in a modern healthcare facility. The current species of Ebola, which is kind of ravaging West Africa, is what's called EBV Zaire. And there are 5 different species, unfortunately Zaire being the one that historically had very high virulence, leading to mortality rates of anywhere from 50+ to about 90% mortality. And obviously the press has really clued in on this idea of a hemorrhagic fever virus. We see a lot of allusion to people bleeding out of all orifices. That's really been an overcall of what we truly see in the disease. And in fact, many of us who practice ICU medicine who've been in West Africa are underwhelmed by the level of DIC that you may see in patients. But it's classically within the group of diseases called the hemorrhagic fever viruses because you can get a coagulopathy, thrombocytopenia, and capillary leak. Again, only a moderate percentage of folks, anywhere from 15 to about 40%, develop those symptoms. And the DIC all of us see in modern ICUs, from my experience, is considerably worse than what is going on from Ebola. And then the next graph just takes us to where we are right now. Clearly the outbreak is much larger than anything that's been experienced before. The case fatality rates are not as high as been described before in Zaire, but the impact on 3 countries in particular, Guinea, Liberia, and Sierra Leone, is very significant. There's been a small number of cases imported to Nigeria and Senegal, and most recently Mali. And then in Europe, most of the cases were expat healthcare workers that were brought back for treatment, except there was 1 secondary case in Spain and 2 secondary cases in the US from healthcare workers who were treating people with Ebola. So where are we in terms of West Africa? Well, what is believed to have happened is that the initial cases started in December 2013. By March 2013, Doctors Without Borders, or what's called Médecins Sans Frontières, MSF, started to report that the outbreak in Guinea was getting out of control. There was a difference in agreement between various organizations of how extensive this outbreak was going to be, but MSF had really shut off the flare early and proved, unfortunately, to be correct. When you look at the graph in the bottom left, you can see that there were not very many cases back then, but it was already clear that the numbers were larger than what had been expected in previous outbreaks, and more importantly, the disease had spread to urban areas. And once it got into urban areas, the public health controls that were usually used, mostly about isolating rural communities, were no longer successful. And we've really seen exponential increase in cases, mostly in Sierra Leone and Liberia since then. Looking to the right, the graph is of West Africa. The map is of West Africa, where the larger the yellow circles, the more cumulative cases that have occurred in the past 21 days. And this is a recent map just showing the extensive burden of disease throughout Sierra Leone, throughout Liberia, and Guinea has still some sporadic cases as well. And like I had mentioned, Mali just had a case from a 2-year-old that was imported from Guinea. Meanwhile, in the US, obviously all of us have experienced the frenzy and fear, sometimes appropriate, usually out of proportion to what the risk is in the US. So when you look, there's 13,000 plus reported cases in West Africa, and that's likely an underreporting. But in the US, we've had 5 medical evacuated cases that all went to specialized facilities, and were all treated properly without secondary cases. We did have 2 imported cases, one most recently of a physician who was working in West Africa who noted early symptoms and then presented to Bellevue in New York, and another person who obviously gained a lot of notoriety, a Liberian gentleman who presented to a facility in Dallas. And then there's been 2 secondary cases, ICU nurses who took care of the gentleman in Dallas. So when you're looking at total impact, it's 9 cases spread out over just under 1 million hospital beds in the U.S. over months. Clearly, the risk of seeing someone with Ebola in any one of our healthcare facilities is quite low. At the same time, we know that these infrequent events can have high consequence for your facilities. They could cause healthcare worker illness as well as dysfunction in your facility. So it's not meant to minimize any preparedness for Ebola, but it's meant to put it back in perspective of what is really the impact of Ebola virus disease in the U.S. versus in West Africa. Europe has a similar situation to the U.S. So back in June, the WHO had put out a call for clinicians to assist with the outbreak. I got a call from Rob Fowler, who's an excellent intensivist in Canada, who had been seconded to the WHO, and we discussed his previous deployment to Guinea, and he had suggested that I would be going to Sierra Leone if I could find time in my calendar to be able to go there. We discussed that while the outbreak really had, at that point in time, not made it into the large media channels, at least not consistently, it was clear that it was an outbreak that was out of control. MSF continued to be worried about the outbreak and even labeling it unprecedented. And being an organization that had been taking care of Ebola outbreaks for 20 years, when they are concerned about what's going on, everyone really needs to take notice. Rob and I talked about that, again, that the disease, while historically and in reports in the media, it always sounded like it was an absolute death sentence, and one in which no matter what you provide care to people, that they would ultimately end up with a fatal outcome. He was underwhelmed by how severe many of the patients looked, and they had tried to intervene with modicums of supportive care that could be provided in Guinea early on, and they had some minor to moderate successes. So I thought it was very interesting to try and bring some element of critical care practice, albeit I knew that it would be far from what we do in U.S. facilities, to West Africa, and I was able to find time in my calendar and get coverage from my university, and ultimately by the end of June I knew that I'd be going to Sierra Leone in September. And it's important to understand in West Africa, what are the baseline resources? The countries that have been mostly burdened, Liberia and Sierra Leone, are countries that have just come out of civil war in the past decades. They're incredibly impoverished. Their capital cities are essentially city slums. They're wonderful people who really are just challenged by very, very nascent infrastructure, and something on the order of this kind of outbreak really exceeded anything that they could do. And remember, imagine in the U.S. we struggle with less than 10 cases. Trying to take on cases that are in the thousands really overwhelmed anything that West Africa could be able to do independently. So where is Sierra Leone? Sierra Leone, if you are looking on this map, is down in here, and it's surrounded by Guinea, and to the south of that is Liberia. And I was going to a place called Kenema, and Kenema is here in kind of the south central part of the country, more eastern than western. And again, just putting the baseline of when you go to a country and try and figure out what kind of care you're going to be able to provide, you need to have background on what basic foundation of economic infrastructure and healthcare system do they have. Sierra Leone had a very long, drawn-out civil war. Their GDP is essentially under what George Soros may make in a year, and that's for their entire country of 6 million people. It's a very young country because of war, so nearly half of the population is less than 14 years old. The healthcare professionals are quite limited in the country. There was only 100 physicians for the entire country, and that was prior to the Ebola outbreak. They had pretty dismal public health outcomes in the past, and their life expectancy is obviously quite dramatically less than in the U.S. So when I headed out to Sierra Leone, again, it was important that I needed to understand where I fit in these major pillars. And I was going to be within Pillar 3, which is the clinical care. And the importance of clinical care is you need to give people a sense of hope that there's actually some sort of treatment option for Ebola virus disease, or else getting folks to come out of their communities and be willing to isolate in the treatment units becomes harder if they think they're just going to be isolated from their family, and in fact it's still a death sentence. I was assigned to Kenema Government Hospital, which prior to the Ebola outbreak was very proud that it was the only dedicated Lassa ward in the world. So Lassa fever is endemic in that part of the world, and they had a tremendous experience in treating Lassa, and again took great pride in that they had a lot of expertise in the ability to provide care for Lassa. And because of that, Kenema Government Hospital was chosen as a referral facility for Sierra Leone. The outbreak initially started in the east, where cases came from Guinea to a place called Kailahun, and then ultimately spread west. So if you remember that map I showed you, Kenema is kind of in the south-central. Kailahun is further east. So they first set up a treatment unit in Kailahun with MSF, and then ultimately they became overburdened with patient cases, and as cases moved further west to Freetown, which is the capital, along the western coast of Sierra Leone, as well as other areas such as Makeni and Port Loko, they needed a place to continue to send patients. It was probably just early thought to use KGH as the referral hospital, but ultimately that became concreted in policy, and Kenema Government Hospital really got overrun by the number of cases that they had. There really was very little ability to manage patients elsewhere in the country. For the entire country, we had MSF Kailahun, Kanat, which is an expat participated hospital near Freetown, which only had about 20 beds, Port Loko, which was being managed by an Italian group, and then KGH. So KGH obviously took the brunt of most of the outbreak for Sierra Leone. And prior to me arriving at KGH, the brunt had really had its impact on its healthcare providers. These are pictures from a recent published article that show 3 senior leaders from KGH who all died from contracting Ebola during their attempts to be able to control it in their facility. Prior to my arrival, about 30 some odd healthcare workers had become infected at KGH. A fair amount of them had died. There were no physicians working at KGH providing Ebola care when I arrived. And in fact, the person who I was slated to swap out for the WHO had unfortunately become infected with Ebola several days before I arrived at KGH. So when I got there, really, it was unclear what was happening inside of the treatment unit, because there were very few people who were going in to be able to have any semblance of knowledge of how many patients did we have, how sick were they, etc. So one of the first things I learned when I got to Kenema was no touch. And what no touch really was you needed to protect your personal space. West Africa is a very touching society, but because of the ongoing outbreak, no one shook hands. There were no high fives. There were no even brushes up on shoulders. You really kept your personal space. If you needed to talk on a cell phone, you left it on speaker because no one was allowed to put their head up to your cell phone. We never shared food. We never shared drink. And personal space was really what you were, it was incumbent upon you to protect your own personal space. Even in the guest house where we slept, we had no one come in and clean our rooms. It was just important to get control of your environment. And the reason why we did no touch, and this may even have implication for the U.S., is the early symptoms are very difficult to ultimately link to whether or not you have Ebola. We all have exposure because we're in the treatment unit day in and day out. One of the first things that people describe when they become infected with Ebola is profound fatigue. The problem, though, is we were constantly fatigued because we were working such long hours, and the emotional toll was quite great given the tragedy that we were witnessing. You can imagine even in U.S. hospitals, the emotional toll of providing care in a high-risk environment is quite extreme, and the profound fatigue sometimes is difficult to sort out of, am I just tired because I've been working so hard without a day off, or is this that I have early disease? In addition, people describe serious headaches early on in the disease and also GI disturbance. When you're working in 95-degree heat in Africa, you frequently have headaches, even though you try your best to remain adequately hydrated, and the GI disturbance goes without saying when you're in a country that really is resource poor. It just happens cyclically that someone's going to have some GI disturbance every few days. So really it became dependent on fever being the only reliable objective indicator that we could figure out if someone was starting to develop Ebola among the healthcare workers. So no touch really was a secondary safeguard to reduce the likelihood of early transmission to any of us. In all honesty, I actually don't think that casual contact in early disease is a major way to transmit, but the important thing that no touch does is it promotes discipline. And you'll hear me talk about this the rest of the talk. Discipline is essential when you're dealing with Ebola. It's a marathon, it's not a sprint, and you need to be able to practice smartly day in and day out, because if you get sloppy, then you may have a risk that unfortunately may change your life forever. So how is Ebola transmitted, and when is it transmitted? Obviously, there's been a lot of discussion about this. I think the key thing is to talk about what we know, what we don't know, and what we're doing to this date given certain uncertainties. We do know that Ebola is largely transmitted from infectious body fluids, and it enters into your body either through skin breaks, which is probably a little less likely, and more likely through mucous membranes. And the key part of Ebola management is sicker people with more symptoms have more production of body fluids that are likely to be higher in infectious load. So folks who generally are early in the disease, if you have a huge exposure to their blood, there's a good chance you're going to get Ebola. But if you just have casual contact with them, it's unlikely that they're going to transmit. So most of the folks who are highly infectious are very symptomatic, and they're not simply going out and about. They're prostrate, they lay in bed, they just lay there all day long, and they're not folks who are riding on airplanes generally. They're not folks who are going bowling. They're people who feel absolutely miserable. So the folks who generally get ill as secondary cases are close contacts who are caring for these people, especially if they're sharing bathrooms or helping them clean up from their body fluids, or healthcare workers. And all of us who are on this call are healthcare workers, and we are at risk because the times where people are mostly likely to be infectious is when they're critically ill. And most of us, if not all of us who are on this webinar, practice in those environments. So it's the intensity of the exposure and the duration of the exposure. So it's not to minimize that and say that Ebola is not very infectious. It is, but only in certain parts of the disease course is it infectious. In fact, we've seen nearly 500 healthcare workers have gotten infected. So to play down its infectiousness is not correct, but at the same time we also need to have a much more nuanced approach to understanding who's at risk and when. In addition, there's been a lot of talk about whether or not fomite transmission plays a role. And what fomite transmission is that infectious body fluids end up on a non-live surface, and the question is for how long are they infectious? If I brush up against that and then touch my face, am I likely to get infected or not? The virus is actually not very robust, and in fact, the virus dies quite quickly in environments, but the environmental conditions matter in terms of how quickly that virus may die. So if you have virus in a bunch of stool that's sitting somewhere, it's probably likely going to have more longevity in that environment than if you have virus that is on a dry surface out in the sun. Again, the humidity things are not entirely understood in Ebola, but fomite transmission needs to be considered, but it's not a big player. And the last one is airborne, and obviously, especially among the respiratory community, this is one of the big ones that people are concerned about. We don't think in West Africa that airborne plays much of a role, although it's not really clear when the patient's very sick and has projectile vomiting or has copious diarrhea, whether or not you can see some aerosolized movement of virus ultimately infecting other surfaces and having airborne to fomite transmission, or someone actually just breathing in from there. The epidemiology would suggest that that's quite limited, but again, it's still uncertain. I think the bigger reason to be concerned about it is in the U.S., most of the things that we do to patients don't happen in West Africa, so we have very little data on delivery of supplemental oxygen, delivery of medications to the airway, mechanically ventilating patients. We just don't know exactly what that will do to the virus and whether or not that will increase the likelihood of spread from the airway to another person. So what do we know? Most of it, unfortunately, we know from previous outbreaks, because even though we've had thousands of patients here, the science is still not kept up with what we're experiencing in West Africa. So in 2007, from a previous outbreak, they looked at whether or not PCR, so a molecular test for the RNA of Ebola, was found in clinical samples, and it's actually surprising how limited it is. However, we still need to be cautious because that is a different outbreak and also quite a limited sample. From the recent patient who was described in the New England Journal in Germany, we see actually that the viral load in blood is quite significant. But then there's a phase change where the viral load in sweat actually becomes significant later on. We don't know what to make of the persistent viral loads in urine. So I think it's too hard at this point in time to be absolutely rigid and say that this is how it's spread and this is how it's not spread. I think we need more information. I think the safe things to assume is in the natural course of disease, the most likely way you're going to spread it is through direct contact with body fluids and then someone self-contaminating themselves from the body fluids. But all bets are kind of off in U.S. healthcare facilities of how this disease may in fact be spread from what we do to patients, in addition being able to sustain patients through much more severe illness than may in fact happen in West Africa. And this is just one more slide that presents, again, at least the epidemiologic experience that if you look down during exposures during late illness, you can see that most of the significant risk for becoming a secondary case of Ebola is exposure to someone in late illness and also doing something way beyond casual contact, although the conversation issue is not entirely clear whether or not that's just casual contact or if that in fact means that's a surrogate for doing other things that potentially expose you to that person. And then lastly, the fomite transmission. Most of the data on fomite transmission came from Dan Bausch's study in 2007, where in a previous outbreak, they just were not able to find RNA on inanimate objects despite care being provided in there. So this suggests, obviously, you need to disinfect properly. So this is where disinfection was done well. But you can, again, see the virus release is not just teeming everywhere. I again would caution that this is one small study, and we need to know more about this for this current outbreak. My understanding is that the Canadian Public Health Lab and MSF are looking at doing more of this evaluation, and hopefully other groups are, to be able to give us more information about whether or not indirect contact, meaning fomite transmission, is more likely to play a role. The other thing to point out is, even if you get RNA from inanimate surfaces, it doesn't mean that it's actually infectious. It just means that there's RNA there. Ultimately, the test would be to prove that virus can be cultured from those areas. So I think we need more data to be convinced that fomite transmission doesn't happen, but I think it's fair to say that it's a less likely means of transmission than direct contact with body fluids. So I'm sitting in Kenema Government Hospital. I know that a whole bunch of people had already been sick. I had spent my career, working with PPE, but this obviously was a situation that was dire and concerning. So I looked to the folks who were already there to give me a quick lesson in how do I stay safe. And I just lucked out that I was with an amazing, albeit very small group of people who were able to keep us safe out there. And safety really, again, comes down from you need to understand why you're doing what for your personal protective equipment. The first part of Ebola care is to recognize it's not episodic. So this is not like you're running in and out of the room to check on a ventilator. You're going to be in the patient's room for a while. And the reason for that is taking off your personal protective equipment is a long and onerous process and a high-risk process where you may self-contaminate. So going in and out is likely to put you at very, very high risk. The flip side is when you're in a unit or caring for someone for hours at a time, having just the front of your body covered with a loose-hanging barrier gown as had been originally recommended just doesn't make sense. There are way too many things you're doing that have you brush up to body fluids or up against patients, so it's crucial that all skin surfaces must be covered. Not because I expect that you're going to get virus to go through your skin, but in fact you could have virus on your skin, you touch that part of your skin, we're constantly touching our skin and then touching our mouths. It's just something that many of us don't even notice that we do, but you can imagine in the right set of circumstances that you can get the disease from that happening. In addition, you really need, the idea of escalating PPE doesn't make a lot of sense because you're at high risk if you get projectile vomiting on you. That doesn't take a genius to figure out. It was very hard for us to predict who was going to have that. So people early in their course, clearly if they're day one of symptoms, they're unlikely to have projectile vomiting. But it's hard to really sort out, is it day one, is it day three? And people sometimes will vomit without any warning. So I would recommend that you put your best foot forward and start with their highest level of PPE until you see the disease starting to really back down. There are some people who have where it looks like they're getting better and then they have worsening of disease, so you don't want to put your guard down. But in fact, if it's clear that the patient's convalescing, there may be a consideration for changing some of your level of PPE. But again, in an early patient, I've seen a lot of people say you can just start with limited care. It makes sense from the idea that early disease is less infectious than late, but again, the issues of projectile vomiting and being someone who's been in the line of fire, you just don't want to be that person who wishes you had more on when that happens to you. You need 100% discipline when you're in there. This is no game. It's not a theoretical risk. It's a real risk. And again, it's not just paying attention when you're doffing. It's in fact the entire time you're in there. You should be deciding, is it even necessary to examine this patient, or am I not going to learn anything from them? We walked around with our hands on our chest just like you do in the OR, making sure you had good proprioception of where your body was, so you just limited your exposure. Knowing where your high-risk exposures are is also important. It's your chest, your abdomen, your gloves, and your boots. So when we doff in West Africa, we actually disinfect those areas with bleach knowing that it's very hard to get all of your PPE off, especially when there's a high infectious burden on your PPE, to do that without self-contaminating. So we use disinfection in addition to safe doffing procedures to make sure that we limit the chance of getting sick from taking the PPE off. Most importantly, the science needs to catch up with practice. Currently, there's a lot of opinion out there. There's limited science, and we need more science on how to keep people safe. So supply chain was obviously an issue in West Africa, as many of you read in the media. But supply chain for MSF and WHO was not as bad as it was early on. So we actually had fairly good PPE, and we employed mostly a hybrid of MSF and WHO theories. We did not follow any of the CDC guidelines. We used much higher levels of PPE than they recommended because we were going with what was time tested. MSF had been involved with Ebola for over 2 decades, so we thought, given their experience and their very low infection rates, that it's important not to fix something that ain't broke. The CDC recommendations prior to October 2014 were mostly considered dangerous by us who were working in West Africa. And again, this is not to sling mud, it's just to be honest about it. Was not a surprise. It was sad, but not a surprise when we learned of folks who got secondary infections in Dallas. They were just not practicing anywhere close to the same level of protection that we were using in resource-poor West Africa. And I think a lot of it had to do with most of the recommendations were not steeped in a lot of recent experience. The CDC personnel used to be very involved in previous outbreaks with management of dead bodies, with going into homes and doing contact tracing, and even providing clinical care. At least when I was in Sierra Leone, CDC personnel were prohibited from any potential exposure to people with EBV. And this is, again, not to sling mud, but the way you learn how to protect yourself is from doing. And again, it's the experience of doing that tells you whether or not what you're doing needs to be changed or not. And most of us, again, look to the experience of people who've been doing this for decades to be able to guide how to stay safe. So this is just a set of slides of the basic PPE that we donned. In the US, again, you're using slightly higher levels of care, but they're relatively similar. So we used fluid impervious boots. We used a Tyvek-like coverall. And then just as one of our pearls, we cut little thumb holes in the coveralls and then put our first set of gloves through that thumb hole so that your sleeves would not come up. And that way you would not have any breach in your PPE between your gloves and your sleeves. We ultimately used an N95 respirator. Again, controversial whether you need it, but we thought there was a fair chance of aerosolization due to body fluids. We used eye protection. And ultimately, we used an apron, second pair of gloves, and you're off to the races after your buddy makes sure that you're good to go. Of course, this was really hot, so the time started clicking away as soon as you were putting on your PPE, just so that you didn't get fatigue or ultimately have volume issues when you were in your gear. And most importantly, we did disciplined doffing. So you may have been in the treatment unit 25, 30, 40 times. When you came out, you did not do anything without being commanded under a strict choreography by the person who was disinfecting you. That way, if your mind was thinking about what you just did inside, if you had heat on the brain, or if you just got sloppy because you've been doing it for so long, right? The big times where you get sloppy is early on when you don't know the process, or later on when you're too familiar with the process and you actually skip a step. So we had the person who was disinfecting command and you had to follow the command to a T. You never did anything prior to them telling you what to do. And I think that discipline is very crucial. You'll see a lot in the U.S. about observed doffing. I just think that's watching the train wreck rather than actively managing doffing to make sure, again, that someone adheres to the prescribed policies and practices. So the take-home messages. Close contacts and healthcare workers are most at risk. Risk increases with severity, and it's clearly high if you have unprotected exposure to body fluids. Healthcare workers who are taking care of the sickest people are at highest risk, and unfortunately, they just can't buy some PPE and be safe. You have to adhere to excellent practice 100% of the time when you're in the PPE. The PPE is only a tool. It's not going to keep you safe if you violate the rules of how to use it. Fortunately, in the U.S., no contacts of early symptomatic cases became ill with EBV. So I'm not advocating for, again, a lack of discipline or just people saying there's no risk and we do not need to do early isolation in U.S. hospitals, but it's important to note that the highest risk is with the sickest people. Most transmission, as I mentioned, is direct contact. We still don't know the extent of airborne indirect contact, especially in the U.S. And importantly, as I had just mentioned, a passive safety officer outside a treatment space is really submaximal. You'll see that in a fair number of policy documents. It's got to be an active person. We employed buddies in the Ebola treatment unit because you want that person to prevent you from doing something rather than just witness you doing something that's a breach in your PPE. How about for developed countries? Well, actually it's pretty similar. West African transmission and prevention is more similar than it is different for resource-rich environments. Like I mentioned, we'd love it in the U.S. if you can just buy something and we'd all be protected, but that's not going to be the case currently. In transmission, we have better environmental controls, such as airborne infection isolation rooms that have air exchanges and are able to take care of small particles that may still be floating in space much better than you can do so in West Africa. But at the same time, we do things that are much more involved in patients, so we may be generating certain transmission mechanisms that weren't actually ever seen in West Africa. I think airborne precautions are not unreasonable. Sometimes they could be a distraction, but generally they're not unreasonable if that's really what the institution is going to do. And it's, as I said, we just don't have enough data to understand whether or not that's going to be a large role or if that actually is going to get in the way of the response. Many hospitals are using PAPRs, even above N95s, and that's also reasonable. I think it comes down to people who know what they're talking about from an industrial hygiene mechanism, from a safety officer point of view, from an infection control point of view, and a human factors point of view need to weigh in, and folks need to decide what's likely to be the best way to protect their healthcare workers. If they are using PAPRs, the half hoods really don't make sense. You need to have a way where your PAPR is going to integrate with the rest of your PPE so that you, again, have no skin showing. And I think there's less discussion in the U.S. of disinfection than I think is necessary. We don't know whether spray disinfection aerosolizes or is effective versus wipe disinfection, which actually may put your disinfector at risk because they're so close to you. So we don't ultimately know the answers are, but it's important to consider whether or not we need to reduce infectious burden on the PPE as you're taking the pieces off. So now let's get into treatment. It's important to understand how we organized an Ebola treatment unit in West Africa because it's got implications for how you should do care in the U.S. We started at first with the suspect ward, and it was termed the annex at KGH. And it was people who were triaged as suspect cases, just like maybe triaged to your emergency department or somewhere else in your facility, who we just don't know whether or not they have Ebola yet. But based on case definitions and other suspicion, you decide whether or not they should be in there or not. We got a fair amount of patients brought in by ambulance overnight who were just kind of dumped, for lack of a better term. in the annex, and we had to sort out. So we ended up having a mixture of people who both had Ebola and folks who did not have Ebola. Then we had our confirmed ward, and that was really where definitive care was to take place, and that was our best place to be able to provide care, although I will discuss with you guys it was highly limited, so I use best in quotes. We used a convalescent ward, which is unlikely to have much of a role in the U.S., but that's just when you have such a burden of patient numbers, when people are starting to get better but haven't cleared the virus from their blood yet and can't be discharged. You want to sort them away from your sicker people so that you can really concentrate on your sick folks in your treatment unit. And the important thing is, in the U.S., we don't think a lot about flow, and it's very important to think about flow, especially if you have more than one person who's suspect in your facility. It's okay to cohort people who both have confirmed Ebola Zaire. We do not think that you can get reinfected. We don't think that if you get exposed again that it makes your disease course any different. So it's okay to have two people in the same room ultimately have Ebola. But if you have one person who you suspect and another who's confirmed or becomes confirmed later on, the last thing you want to be doing is going back and forth between those patients. And in West Africa, we tried to do the same thing. It's very, very important that you don't go managing someone who's sick with Ebola and then go talk and examine someone who likely does not have Ebola because you've just exposed them. So going in, so my buddy, who was an Ugandan physician, Henry Kyobe Basa, and I, we were linked, so we always went in together. And we typically spent 4 to 6 hours or so in the Ebola treatment unit a day. We would always have a plan before we went into treatment unit so that the goals and objectives were laid out, because you could get distracted from emergencies happening and other things going on. And if you don't stick to your plan, ultimately, when you have, we had at our maximum probably over 115 patients in there for several docs, you're just not going to be able to do the best for everyone if you, again, get distracted for a single patient. So it was very important for us to do that pre-entry briefing to be able to stay on task when we were inside. We checked each other's PPE before we went in. Our hands went to the apron, as I mentioned, just like in the OR, and you start in the suspect ward. And of course, the first time I went in, I said to myself I'm not sure I said stuff, but I said, this stuff better work going in. So we worked very closely with the local staff from KGH. Again, this was part of our briefing process where we would talk with them 10 or 15 times a day to really try and organize everything that we were doing, from prioritization of delivery of care to just sorting out if the generator's not working at night, how can we make sure that the patients have lights at night. The annex was less than an optimal facility. It's that building in yellow in the back, very dingy inside, rooms that were very, very difficult to clean, in beds that were difficult to clean. Overflow was outside. Most of the non-ill patients were smart enough to sit outside in the annex and stay away from the other patients until they were either determined to have Ebola or not. So going in the annex, we would enter through the gate, and the important thing is we would pass most of the folks who had severe Ebola who were waiting to get confirmed before they went into a treatment ward were in the rooms, and we would pass them at first. You didn't want to get distracted and immediately start caring for them, because again, if you're trying to sort out all the other patients that you need to get phlebotomized to prove that they do not have Ebola and get out, you don't want to be, treating someone, putting your hands on them, touching body fluids, and even after disinfecting with chlorine bleach, then going and talking to someone else, putting your hand on their shoulders as you're conversing with them or examining them, because you're just going to lead to cross-contamination. And ultimately, a lot of what we had to do was just to try and figure out what was going on in the ward. Simple things like knowing who the patients were was nearly impossible. The system was highly broken, and we spent much of our time just trying to sort out who the patients were and reestablish flow in the units. This was our high-tech way of figuring out who was in the unit, and we would take an iPhone picture before we would have to throw this paper out because we couldn't bring anything out from the hot side into the low risk side once it was in the Ebola treatment unit. So our goals were get people out if they don't need to be there. Again, not too dissimilar to what the U.S. goals are. Most of the patients who are going to come to your hospitals are not going to have Ebola. And patients who are suspect with Ebola are very time-consuming and really risk the entire functioning of that particular unit caring for them, even in U.S. hospitals. We had great laboratory capability. In fact, the CDC lab throughput was much greater than what I've seen in the U.S. But the key thing was, again, keep people separated. Just because someone was suspected of having Ebola, the last thing you want to do is give them a death sentence from actually giving them Ebola from being in the unit. And then what do you do when more patients came in? You know, I think in West Africa we managed this probably much better than we do in the U.S. currently. You know, MSF would disinfect their ambulance and turn around and they'd go and get more patients. But remember, in Dallas, they just didn't know what to do with their ambulance for days until they sorted out how to get that unit back and running. So I think policies and procedures need to be in place of how do we actually keep our systems functional rather than just throwing our hands up and going, oh my God, you know, something awful has happened in this ambulance and we have to get rid of the ambulance. That just doesn't make sense from the science that we know about the virus. So persons under investigation, PUI, you'll hear more and more. This is the term that public health uses for the people that they are trying to evaluate for Ebola. And there's obviously screening criteria that many of you are familiar with, even though it's rapidly changing in the U.S. I believe that every U.S. healthcare entity needs to have a way to screen, temporarily isolate, and protect the healthcare workers from Ebola. That does not mean that every healthcare facility needs to be able to treat seriously ill Ebola. The two issues are somewhat separate. But we can't control where the patients present. So for facilities to think that they're out of the line of fire, I don't think that's true. The likelihood of getting any facility having an Ebola patient is incredibly low. Most of the likelihood is you're going to see a trickle of people coming back. Occasionally, a healthcare worker may get ill during their incubation period back here, or a traveler may get ill. But on the most part, it's going to be very few numbers versus how many healthcare institutions we have in this country. The best way to really start to figure out whether or not someone has risk is their travel time. So were they recently at a place that has risk? Screening simply on fever, you're going to see many more fevers than you are going to see people have Ebola. So I think the best screening question is first, were they in the right place where there's Ebola? And then the second best question is, did they have contact to someone who was sick? Even in West Africa, very few people are getting sick without sick contacts. Here's a screening. I think the one pearl to take home on that is the screenings generally case definitions from public health. They need to be translated so that they're clinically operational. And importantly, just asking someone if they have nausea and vomiting isn't as useful as asking them the duration of nausea and vomiting. If their nausea and vomiting has been going on for 3 weeks, I assure you it's not Ebola. Ebola is a short duration, self-limited disease. So it's worthwhile actually not only asking their symptoms, but understanding how long they've been there. The biggest problem is once you screen someone and isolate them, most of your diagnostics for alternate diagnoses go away. And that's really the struggle we have of immediately isolating people, although you have to do so until you can figure out what the risk of the patient having Ebola is. And so importantly, you need to understand how we diagnose it. The test that's doing most of the work for diagnosis is a molecular test, a PCR, for Ebola. And they're being done through the Laboratory Response Network. Some states do it in their state, others have to send it to CDC. So the turnaround time can be quite delayed for some places. In addition, just the number of primers available is quite limited because most of public health's posture has been they're there to confirm, not to rule out. I would argue the biggest trouble we have in U.S. hospitals is actually the rule out, because the rule out is so much more common than the rule in, and the rule out takes so much effort and energy, just like having someone with Ebola is. And honestly, if I find out 6 or 8 hours later and someone who I really was pretty sure had Ebola, if it's delayed that much longer, it's not that terrible. What I really want to do is rule that person out who doesn't have it, so I can open up my emergency department to normal flow again or close down my Ebola isolation unit. Fortunately, there is more testing capability available at hospitals. BioFire just got emergency use authorization approval from the FDA in the past week and a half, and these kits do not require very high BSL level to be able to run them, and they're a molecular test for Ebola. So that's probably going to help us do more tests, but we still struggle. I point out the red circle. The detection threshold early in disease is right about where the median level of virus is in the blood, meaning people on the first day of symptoms may actually have Ebola and the test may be negative. So from previous outbreaks, the teaching is that you really need to go 3 days to be able to rule it out. Unfortunately, this is still based on relatively low numbers of patients, and we need to update to find out, is that 3-day window still true nowadays, because the shorter we can make it, the better. So general isolation strategies, patients cared for in a dedicated space and not moved. Diagnostics, it's important to know which point-of-care test that your facility is going to use. Even though the CDC says you can use the general lab, I don't know of any facility that's using their general lab. Most radiology is not going to be used either, so bedside ultrasound is going to be the mainstay. The American College of Surgeons have put out guidance on if you're considering doing surgery for patients with EBV. I'm not sure when I would consider that or if I would consider that. We do know from previous outbreak that when surgery was attempted, and I'm not sure what the personal protective equipment was used, that all of the providers who participated in the surgery became infected with Ebola. So where's the downside to this? Why don't we just isolate everyone? Well, the problem is more people are likely to come from these countries who have traditional healthcare problems than Ebola. And if they have a time-sensitive problem and you decide to isolate them and you take away their diagnostics, they may in fact have a life-changing event because they were put into isolation for Ebola, they didn't have Ebola, and they were harmed that way. So it's important for your facility to have a plan on how they're going to decide what's best for the patient, but yet how is staff and facility safety taken into account, and especially if the decision needs to be made before the PCR test can come back definitively. We've started to play with the idea of a rapid EBV assessment team so that we can not only assess the likelihood of EBV in the patient, but what's the risk also if we delay diagnosis or treatment for the condition they have, and then what's being proposed. So if it's just a CAT scan, maybe we can minimize the risk to facility or to staff versus is it an invasive procedure with a lot of body fluid likely to lead to potential exposures. I recommend that a multidisciplinary team be considered. It has to have the right people, both clinical people as well as ID and public health people and risk management. And most importantly, it needs to have the endorsement of the facility. You're just going to be able to make the decision with the data you have available, and you won't know until after you know whether or not you made the right decision. But you can clearly see if patients having chest pain and would be advised to go to the cath lab, and you decide that the patient's very high risk for Ebola and they don't get to go to the cath lab and they don't even get TPA because of the chance of having Ebola, and in fact they didn't have Ebola and they did have an MI, obviously that will weigh heavily on the clinicians and on the institution, and it's important that the institution has the clinicians back. So back to the annex, once we finished with the suspect people who were likely not to have Ebola, we went on to people who likely had Ebola. And our mainstay of therapy was water and oral rehydration fluids because people had copious diarrhea, on the order of they could have up to 10 liters a day of diarrhea. So similar to cholera, typically happen 5-6 days into symptoms. Usually nausea and vomiting preceded that by a day or two, followed by the diarrhea. In addition, because we saw a fair amount of co-infection of malaria, and remember, if the patient rolls in for malaria in the U.S. but they're suspect Ebola, you can see co-infection. So we would treat empirically for malaria just because we could, and we would also treat in the GI stage for translocation of bacteria, although that's quite controversial. And the most important thing to understand is even though we saw, I personally saw hundreds of cases, you only have about 60 to 90 seconds to see per patient. So the actual experience is broad, but the learning from the patients is somewhat limited. So it's hard sometimes to translate what you would do back in the US. So on to the confirmed ward. The important thing in this slide is to recognize that not everyone gets sick from Ebola. Some people do, some people don't. We don't understand why. But what are some of the signs of someone who's getting sick? Well, I would look for, were people walking? If they're walking, they're probably doing okay. If they're eating, they're probably doing okay. If they're under blankets, they're probably not doing okay. And obviously, if they have signs of bleeding, which we only saw in a minimal number of people, that's a very worrisome sign. In fact, the experience from West Africa has recently been published the first 9 months in the New England Journal. And the important things to note are altered mental status is one of the big issues, and so is age. So people who are old do very, very poorly. Pregnant women do poorly, and people who are altered do poorly. In addition, from the bleeding, actually the biggest concerning stuff is when I saw nosebleeds, I got really worried. When I saw bleeding gums, I got really worried. And that's just been borne out now in the series as well. So in the last few minutes, we'll just talk about organ dysfunction. What hasn't got that much play but is truly a huge part of this disease is the neurologic dysfunction. The cause of the encephalopathy is not clear, whether it's direct virus invasion of immune tissues in the CNS versus is it all of the laboratory abnormalities from the profound electrolyte disturbances that patients have due to their diarrhea. Whatever may be the cause, it gets in the way of their care. They're very agitated, and our big struggle is we had to balance sedation with we could not put an airway in and mechanically ventilate. Cardiovascular, you don't see shock as a major element, but you clearly do see a component of hypovolemia in the patients. Again, they lose a lot of volume. How much to volume resuscitate remains a point of controversy. I think in the West we may be overdoing it, and in West Africa we underdid it. Whenever we could do it by PO, it was great, but almost all of these patients who were getting sick were too sick to be able to take sufficient PO to make up for their losses. So we would use parenteral IV therapy, and ideally balanced IV crystalloids are the best, such as plasma light or lactated ringers. For hyperemesis, there has been some argument of whether or not they have ileus or whether or not they have pancreatitis. You obviously just manage it supportively. And same with the diarrhea. Whether or not you should use a stool collection device, I would advocate for that in the U.S., such as either using a Foley catheter in the rectum or using or using any of the fecal collection devices that are common in the ICUs. Whether or not you want to use a gastric slowing agent is controversial. There's some benefits and minuses, and I think that's something we just need to learn down over time. If the stool output, though, is so profound and you can't keep up with volume, then I think it's reasonable to do so. I think that's more an issue in West Africa than in the U.S. So in the resource-rich environment, the problem is, or the good thing is, we've had very few patients. So it's hard to really understand all of the critical care issues surrounding EBD because we really could not do much of that in West Africa. You know, most of our patients are healthcare workers who've been medically evacuated from West Africa. In the U.S., 2 of the 9 patients have been critically ill. 1 died, 1 survived. Quite significant hypoxemic respiratory failure and prolonged acute kidney failure requiring continuous renal replacement therapy. So I think ICU care is within the bounds of something that should be considered. It just needs to be considered and how to do it in a safe way. We did not see much hypoxemic respiratory failure in West Africa, but it's not clear, is that because in the West are doing more volume resuscitation? Is it host factors of who's coming back, given that they're mostly expatriate people coming back? Or is it a survival bias that just people are living longer when they come back here, and it's something that you just don't see earlier in the course of disease? So for respiratory support, my guess is the most likely indications you're going to see is ventilatory failure for people trying to compensate for profound metabolic acidosis. That's what I saw a ton in West Africa, but we just couldn't intubate them and mechanically ventilate. But I saw a number of people who had abdominal paradox and who clearly were no longer keeping up. And I'm sure the Winters formula would have showed that they had ventilatory failure on top of their hyperchloremic metabolic acidosis. There may be hypoxemic respiratory failure. Some has been seen in Europe and some in the U.S., as I said. We don't know if it's ARDS, but it seems like it's ARDS. And then there may be airway issues because the patient's so hard to sedate that they just require an airway to be able to get them safely under control. And that's a reasonable time to put them on a ventilator. I think intubation could be done safely, but timing is the key. And you should never do this as an emergency because emergencies cause people to violate discipline. It's very, very important that you have full discipline in your PPE. So here's my opinion. I think delivery of low flow oxygen is okay through nasal cannula. If the patient starts having increasing oxygen needs above that, especially if it looks like it's rapidly increasing, I would not wait. I would consider elective intubation. Do it when it's urgent or elective. Don't do it when it's emergent. I also think until we know more that high flow oxygen through nasal cannula like vapotherm or non-invasive positive pressure ventilation, while they may be beneficial for the patient, may cause significant harm to the healthcare workers. And again, now you're having to weigh both of those issues. And the last part of that equation is I also think because they are good mainstays of therapy, someone who fails that is much more likely to need a crash intubation, that I would just go on to an elective intubation rather than using those means to forestall intubation, acknowledging that you're going to intubate some people who probably wouldn't have needed it. But it's just, in terms of staff safety, a reasonable way to play those chess pieces. Obviously, you're going to need to make a decision with your clinical team based on what's in front of you, but I think that's some general guiding principles. Also, intubate early, have your pre-procedure brief on how you're going to do the procedure, and also discuss what you're going to do if the procedure comes upon difficulties. This is not the time for your inexperienced people to try an airway. Clearly, it should be only essential people in the room with your most experienced people and minimal numbers of people in the room. So more of my opinion. I think that once a patient's intubated, that we should err more towards avoiding self-extubation than early liberation. And again, that's very controversial. But you can imagine, unless you have the people in the room who are in the room 24 hours a day who are very comfortable managing an airway after from a little more down than you normally would. So I believe that respiratory care professionals need to really give guidance on what is the right balance of using everyday processes for vent checks and documentation versus minimization of having staff in the room. And that's really going to take the guidance of respiratory care professionals to really weigh that right balance. I think EICU communication equipment, if it exists, we've put it in our Ebola treatment unit to be able to remotely look at graphics on the ventilator, etc., for the ETU, ICU docs, could again, and the respiratory care professionals to reduce time in the room. And ultimately, really coming up with a strategy of what's the right balance of what's the right strategy for which type of circuit, humidification, MDI delivery, exhalation filtering, that has to, again, balance what's the best for the patient for what's the least likely to cause aerosolized transmission in the room where the patient's in. So final things, I think we need to have a strategy on hemoptysis. It's very, very infrequent to see, but if it does come up, we just need to be thinking about what are we going to do ahead of time. You know, we may just decide to try and medically correct it. And if that doesn't work, I'm not sure in most institutions bronchoscopy with airway blockers are appropriate. Again, that's going to be a case-by-case decision and an institution-by-institution decision. But this really brings up the bigger issue of there are going to be probably some procedures that you as a clinical group may decide is too risky to provide, especially if they're not likely to provide a lot of benefit to the patient. And there needs to be a process where that's being able to be done, where it does not make it where the healthcare workers feel like their arms are being twisted to do something they don't want to do, and then at the same time making sure that the patient's protected. And of course, peds and neonate strategies absolutely need to be there. I think the one strategy people have tended to forget is the perinatal strategy. So there definitely are people who still come from West Africa who are in third trimester who may have premature delivery due to Ebola or may just deliver. And there needs to be a strategy of now all of a sudden the neonate is also a patient, and how are you going to manage them? Where are you going to manage them? What level of support are you going to provide? So I'll stop right there. Thanks so much, and again, sorry to go over.
Thank you so much, Dr. Rubinson. Pardon me. We do have quite a few questions if you've got a few minutes to answer. One of the questions hit my mind as you were wrapping up here at the end when you were talking about women who are pregnant who are infected with Ebola and potentially delivering premature infants. Would those infants then be infected with the virus itself? Does it cross that maternal-fetal barrier?
Yeah, it's not clear whether all infants will in fact get Ebola, but I think you have to assume that there was potential in utero exposure and there is risk until you can rule it out appropriately. We also saw a fair number of infants who got Ebola when they were breastfeeding, but their time course was different than the mom. So a lot of times the mom would die and then the child would be asymptomatic. But if you think about it, the mom probably got it from an adult exposure, right? And then the child probably got it at some point when the mom became symptomatic infected and had enough virus in their breast milk or just from contact with the mom. So it's about 10 days delayed. It's not really clear in the perinatal period exactly what one, if it's a foregone conclusion that they're going to get Ebola, and then two, what the timing is. But I think the prudent thing would be to immediately isolate and assume that they have it until you can prove otherwise.
Great. So I have a lot of questions from the audience. I'm going to kind of group these together as they tend to overlap a little bit. One of the biggest areas of concern is about decontamination. And earlier in your presentation, you discussed how it was a little difficult here in the U.S. to identify what agent to use for the decontamination of equipment and surfaces and such. What kind of challenges should the respiratory therapist be prepared for as they're trying to ensure that equipment and space are decontaminated here in the U.S.?
So I actually think the equipment, so just in terms of surfaces, any good virucidal will work. When I was talking about the challenges with decontamination, it's actually how do you disinfect PPE as you're taking it off is the real challenge. So some people want to use hydrogen peroxide wipes Others want to use bleach wipes. What we did in West Africa is we actually used 1 to 20 bleach, and we sprayed it from nipple line down, always pointing down, so that you're essentially trying to kill virus, depending on dwell time, relatively quickly. Again, just trying to reduce burden, that if you happen to self-contaminate, that you're less likely to get infected. So the disinfection for PPE, I think, is still controversial, and unfortunately it just requires more studies, but I think the key thing is to make sure your institution is considering it. I personally believe in spraying, but it's not clear whether or not that can aerosolize. That's just what we did there, and that's been a time and tested way, but it's kind of hard to do in a modern facility. But that's what we're doing here at University of Maryland. We're doing some spraying, some wiping. Second issue is disinfecting surfaces. Again, a good virucidal will do this. The virus is not robust. A good detergent will knock it on its bottom and make it where it's not infectious. But then the issue is equipment, such as ventilators, etc. There's different controversies over how do you get equipment back into service. Most places that have done some patients are using aerosolized hydrogen peroxide, something called BioQuell. It requires a contract with your institution. It's a big deal to do it, so the terminal clean is not insignificant. But you have to assume that if you have a real patient, that the ventilator is not coming out until there is a terminal clean strategy. Doesn't mean you need to get rid of your ventilator by any means. There just needs to be a rational strategy of how you're going to terminally clean it. And something like BioQuell is absolutely a reasonable option, but there needs to be an option that's sorted out between public health, industrial hygiene, biomed, respiratory care, and infection control.
So along those lines, how long does this virus actually live on a surface?
It depends. Again, it depends on the ambient conditions. So if you put it on paper in the hot sun, it's probably an hour, dry paper. If it's lying in fluid, we don't know exactly what humidity does to it, but it probably can be recovered at a higher level, especially if that fluid is body fluid. So you can't really simply talk about time on surface unless you're really talking about dried virus, etc. But on the most part, if you're doing a very good job cleaning, most of your heavy exposure area in your unit, wherever you're working in the U.S., is going to be from the patient. Will be less from all of the materials that are in the room, but you have to be diligent about constantly wiping them down.
Thank you. We are now going to switch over to some questions about the PPE. One of the questions is, how long can PPE be safely and comfortably worn? When we're talking about, excuse me, when we're talking about people staying in the rooms for long periods of time.
I've only practiced in U.S. hospitals. I've done it in really extreme heat. In extreme heat, you're usually talking about, some people it's as short as 45 minutes, and others, I usually could get up to a little over 2 hours, and then you're feeling pretty awful. My experience here with controlled climate, and especially if you're using a PAPR that's actually moving air, is 3 hours is probably a reasonable amount of time that you're still safely doing okay. But part of this is also going to be, I personally think that if folks have physical limitations, this is not the game you should be playing. If you're going to be heat intolerant, you really probably should sit it out. The idea of being able to immediately don PPE and rescue someone because they go down is actually a risk you're taking going in there. And it's not a risk that other healthcare workers should own. So if your buddy can get you out, great, and if you just fainted. But the expectation really should be that you're able to handle, and I think 3 hours is a reasonable time, and you're able to handle that workload And if you can't, you should probably tap someone else to do so.
So speaking of PAPRs, one of the questions was whether PAPRs should be used instead of the N95 mask.
You know, I could see it going either way. So obviously, we don't know about aerosolization. The protection factor of a PAPR with a shroud is considerably higher than an N95. As to whether that actually is going to make much of a difference is not clear to me. The other nice thing that a PAPR provides is the face shield's actually reasonably large, and again, it also provides some ability to have more heat tolerance. So I think putting all those together, I wouldn't argue against a PAPR. Did I feel very safe using an N95 in West Africa? Sure. But also, we weren't doing all the things that we do to the airway here. I think if I'm manipulating the airway, my personal preference would be to use a PAPR until we can prove that aerosol transmission is not likely to happen. I think PAPRs are reasonable. But I could see both sides of the argument. PAPRs do make it harder to don and doff. You know, they make it harder to keep the hose clean, to keep the belt and the pack clean. So it's not as simple, we need the latest, greatest, better stuff. You need to weigh the additional burden that PAPR bring. But I think overall the answer is PAPR's probably better if someone's going to be critically ill and you're going to be manipulating their airway.
So switching now over to the physiologic effects of the disease process and treating them, with your experiences in Africa, you mentioned that you didn't do a lot of supplemental oxygen. Did you give patients oxygen at all? Did you bother with mechanical ventilation? How much clinical intervention did you provide as the disease progressed?
Yeah, there was no oxygen to give. So I actually found two very, very awful-looking oxygen concentrators, one that was in the Ebola treatment unit that looked like it had fared better many days ago. But the big problem with oxygen delivery there is there's really almost no compressed gas. And liquid oxygen is not an option. There's no one who manufactures it there. So it's about oxygen generation, oxygen concentration, and the electricity is too unreliable. So even with generators, the lights go out all the time. So it really just was never even an option. So the flip side is we use pulse oximetry to get heart rate because you couldn't bring your wristwatch in. So it was the best way to be able to tell the pulse, and almost no one was hypoxemic. That, again, doesn't mean that had they been managed in a modern facility, would we have kept them alive long enough? But, you know, our case fatality rate was 45%. It's not like everyone was dying. A fair number of people were doing fine, and the amount of care we were providing was embarrassingly small.
So when you were assessing your patients with thermometers, pulse oximeters, stethoscopes, those kinds of things, were you just then cleansing the equipment with the virucidal wipes or sprays?
No, we just let you would use some chlorine, but remember they just stayed in the unit, so the equipment just stayed there, right? Okay. And we would not use stethoscopes. You know, I would argue, especially in the U.S., that an ultrasound could answer most things a stethoscope should do, and there was no way we were putting our hands up near our ears, you know, with our hoods, and the risk of contamination. There probably are times where a stethoscope will tell you something that you wouldn't have gotten before, but it's few and far between. Again, in the U.S., I think bedside ultrasound really provides a fair assessment of the pleural space as well as the lungs. So we didn't use stethoscopes. All we used was thermometers, pulse oximeter, and blood pressure cuff. And most of the time we didn't even use a blood pressure cuff. We would just check the quality of the pulse, but occasionally we would just do blood pressure by palpation.
And the last couple of questions I have are based on quarantine. We've seen a lot of things in the news recently about the nurses in Dallas who were under quarantine, and then a nurse now in Maine who has refused quarantine. And so we're obviously debating the pros and cons and the ethical implications of this 21-day quarantine for returning healthcare workers until such a time as they identify as not infected. Do you have any thoughts about that mandate?
Yeah, I mean, it's a difficult issue, right? You want to make sure that the public is safe and also has the perception of safety. I think we lost a lot of our window of trust when some reassurance from certain organizations came out and ended up not being true. So now there's a fair amount of distrust, which makes the conversation even harder. But if you do it based on science, you know, what I think you do is you tell healthcare workers they will be civilly and criminally responsible, that if they develop symptoms and don't notify someone early enough, that you know, they'll be punished. So if you're checking your temperature 2 times a day and you're watching for fatigue, it's almost impossible that you are going to spread the disease to anyone. Again, nothing's impossible, but almost impossible. More likely that someone's going to get hit by lightning than that happening if someone is diligent and honest and upfront. So I think it's shared responsibility. The healthcare worker, you know, who decides to wait 48 hours or 72 hours of symptoms, I think shame on them, and I think the book should be thrown at them. The flip side is a 21-day quarantine makes it just about that any clinician can't go. Really, I think probably the only ones who can go is military, and they're just don't have a big enough footprint on the ground to do this. You want people who are actually working, who do clinical care. Most of the people who can take 21 days off at the end are people not working clinically. So if we want to get people actually kind of know what they're doing and can make difficult choices, because you need to be a really good clinician out there. That's how you do a proper triaging and deciding what care to provide and what not to. I think the 21-day ends up being a non-starter for just about everyone. I was quarantined for 21 days because I had a risk exposure. That's a different situation. I think if you have a high-risk exposure, you're stuck. So I had to eat the 21 days. But I think expecting everyone to do so is very damaging to the response. And honestly, if the response gets any worse, you know, it's not clear what's happening in Liberia. Maybe we're getting a little better. But on the most part, these countries are on fire. And they could go down, right? So if they stop paying their military and they stop paying their armed police, we think the borders are porous now, those countries will fail. Once they fail, people will spread to the surrounding countries, and then we'll lose our epi-link. So I think if we quarantine people now, all we're doing is kicking the can down the road, where essentially we're just going to have more patients a year from now, a year and a half from now, rather than we just need to actually squash this. We're essentially looking for the least worst of bad decisions.
Thank you so much, Dr. Rubinson. This has been a fantastic session. We really appreciate your time and your expertise.
Thanks. I really appreciate AARC, as always, being able to collaborate with them. And thank you, everyone who was on this, who hung out for so long. I had to run to my next meeting, but folks, welcome to shoot me an email if they have other questions, or let me know how this might be more useful in the future.
Thank you. For those of you joining us as a live presentation, please stay with us for the next brief pause for instructions on how to obtain your CRCE contact hour. If you're watching this program as an archive, this concludes our presentation.